Hello, my name is Vere Borra and I'm a researcher of the Center for Evidence-Based Practice at the Belgian Red Cross. I'm also a coordinator of the Cochrane First Aid field and I'm a member of the ILCOR First Aid Task Force. In this presentation, I want to talk about the use of limited evidence in guideline development. So the first step in the guideline development process is the prioritization of research questions. So for each research question, a PICO question is formulated. Based on these PICO questions, search strategies are developed and searches are done in multiple databases. The next step is the selection of the evidence and the extraction and synthesis of data. Finally, quality assessment of all included studies is performed and a level of evidence is assigned according to the grade methodology. Then you can formulate recommendations based on the evidence. These are all steps that are done, for example, by the ILCOR First Aid Task Force. The final product of these steps is a co-star or a consensus on science and treatment recommendation. These co-stars can then be used for guideline contextualization and implementation and evaluation of the guideline. And this is mainly done by the guideline organizations such as the ERC, the American Heart Association, the American Red Cross, or the International Federation of Red Cross and Red Crescent Societies. Final product is an evidence-based guideline. In developing evidence-based guidelines, it is important to keep the three pillars of evidence-based practice in mind. It starts with looking for the best available scientific evidence, but always keep in mind the preferences and available resources of the target group and the practical experience and expertise of experts in the field. To make a recommendation, you need to make a balance between the certainty of evidence, but also the benefits, the possible harms or risks, and the costs. If, for example, you have high or moderate certainty evidence, there are low costs to the intervention, and there are some benefits, then you can make a strong recommendation. If, however, the certainty is of low to very low certainty evidence, there may be some harms to the intervention, or there are some risks involved, or the costs are high, then you can only make a weak recommendation. If no evidence was found, good practice points can be formulated. A good practice point is a point of common sense, or where the expert panel reaches consensus about. But what if you only have limited evidence? And by limited, I mean both in terms of quantity and quality. For example, the storage of an avulsed tooth. This is a systematic review that was done by the ILCOR First Aid Task Force. One of the storage solutions we identified is oral rehydration solution. Two randomized controlled trials compared ORS with milk, but this was only very low certainty evidence. But ORS is available in all first aid kits and it is easily used in the most settings, which is why a weak recommendation was made in favor of using ORS. A second example is the use of cling film to store an avulsed tooth. We identified one RCT comparing cling film with milk. Also very low certainty evidence, but cling film is found in most households, it is widely available and it has only limited costs, which is why also a weak recommendation was made. What if you don't find any evidence? In that case, you can go back to the first step of the process, the PICO question, and you can look for indirect evidence. You can do this by broadening your PICO question, the search strategy, or the selection criteria. So for example, look for different study types, lower study types, or different settings. You need to keep in mind that the overall level of evidence will be downgraded because of indirectness. If you still cannot identify any evidence, then you can formulate good practice points. An example is the use of compression wrapping for closed extremity joint injuries. This is a systematic review that was also made by the ILCOR First Aid Task Force. No evidence could be found in the pre-hospital setting, which is why evidence from the hospital setting was included. But also in the comparator group, in most studies, some kind of standard first aid treatment was used, such as elevation, ice, or a splint or a brace. This may lead to possible confounding of the results. So we did identify evidence, but we couldn't make any recommendation based on the evidence, not in favor of compression wrapping, but also not against compression wrapping. So no treatment recommendation was made. An example of a good practice point when no evidence was found is the use of cling film for burn wounds. Only in vitro studies are available looking at the sterility of cling film, but experts indicate that you can use cling film to cover the wound during transport to professional help. What if you find conflicting evidence? Then you need to look for an explanation. Is there maybe high study bias in one of the studies? Are there confounding factors that they didn't take into account? Is there high heterogeneity? If you can find an explanation, then you can still use the evidence to support the recommendations. If you can't find an explanation, then you need to treat this as if no evidence was found. But you still need to check the different outcomes and take into account the outcome priority. An example again of the systematic review of storage of an avulsed tooth prior to replantation is the use of coconut water. We identified 4 RCTs using coconut water compared to milk. 3 of these studies were in favor of coconut water, while 1 study was in favor of the comparator, milk. We couldn't find an explanation for the conflicting results, so no recommendation was made. What if evidence and opinion are conflicting? Then you need to check if the context is the same. Are we talking about the same population, the same intervention? If the context is different, try to adapt the recommendations to the specific context of interest. If the context is the same, then you need to make the balance of benefits and harms and take into account the certainty of evidence. For example, the use of rice water to store an avulsed tooth. We identified 1 study that shows benefit for rice water. However, the experts indicate that if rice water must be made, this could create a delay. It may therefore be preferable to use an alternative storage technique that is readily available. So no recommendation was made. I want to conclude with a take-home message. Guideline development is more than evidence alone. It has the best available scientific evidence at the basis, but always keep in mind the preferences and available resources of the target group and the practical experience and expertise of experts in the field. Thank you for listening to my presentation. If you want to contact us at the Center for Evidence-Based Practice, visit our website or send an email. You can also follow us on Twitter and LinkedIn. If you want to learn more about the Cochrane First Aid field, visit our website or send us an email and we will get back in touch with you. You can also follow our work on our social media channels. Thank you.